new to the practice, started here in September. Amy asked me to do a presentation for everyone. Basically, what do I do? Some people aren't sure 100%, so Amy asked me to do this presentation. I know everybody, but I don't really know everybody, and I don't think you know me as well too. So I kind of wanted to start with like, who am I? Like a little bit about me. I was born and raised in New York. I went to college down at Johns Hopkins in Baltimore. And then during my time there, I actually played football and suffered an injury to my knee and my ankle, and I actually had my ACL repaired. And through the rehab process, I met a podiatrist down there and started to talk with him about what he did and about his lifestyle, and I thought it was a really kind of cool thing to do. So that's when I decided to apply. Went to school in New York in Manhattan, and then did my residency in New Jersey. It's not common to do a fellowship in podiatry. It's getting a little more common now, but I applied for fellowships throughout the country and matched up with Cleveland, closer to Cleveland. And I really liked Ohio once I moved here. People are very friendly compared to where I'm from. The traffic is significantly less than anything I've ever experienced, and the cost of everything is a lot cheaper. So it fit my lifestyle more and my family. So definitely decided to stay in Ohio. And then when I interviewed here, I met with Dr. Knappich, Dr. Whitmer, Dr. Miller, Paul. Got to tour, got to meet some of you guys here, and I just thought it was a great environment to be a part of. So I was really excited to join, and so far it's been working out well. So what am I? First, I'm a family man. I really do enjoy spending time with my family. Number two, a doctor, helping people, and number three, just a big old softie. I don't know who's known me by now, but I'm a tough exterior. I don't know. So what is a podiatrist? A lot of people, when I talk to them and I say, first, they ask what you do, and I say I'm a podiatrist. They say, oh, you like dealing with kids. And I say, no, that's a pediatrician, pediatrics. I'm a podiatrist, podiatrics. And it's not just a foot doctor. It's pretty much all encompassing, depending on what state that you're in. Now, each state has different laws of what we can and what we can't do. But here, the great state of Ohio, pretty much from the toes up to right below the knee. So all encompassing there. According to Wikipedia, it's a branch of medicine devoted to diagnosis, study, treatment, surgery of the lower extremity from the knee below. So there's a lot of subspecialties. One of the main reasons I really enjoy podiatry is because there's a lot of different things you can kind of hang your hat on. There's trauma, which I'm sure we're used to seeing through here. Wound care, which anybody who's worked with me has seen a couple of wounds as well. There's a sports medicine aspect. There is actually a pediatrics too. There's a special called Podiatrics that some people go into dealing with kid deformities. Dermatology, deformity correction, microsurgical, which deals with nerves, veins, and plastics as well. So conservatively, what I hang my hat on conservatively would be orthotics. I'm one of the most flat feet you'll ever see in your lives. So any way that you can support the foot in the arch as you're walking, as you're doing your activities, is something that I've seen not only benefit myself, but benefit my family and my patients. Other things, custom shoes, especially for diabetics, and offloading. A lot of times, wounds or pressure points in athletes are a source of pain and it can inhibit their daily activities. So I really try to help them offload those areas to get back to doing what they want to do. Injections, I give a ton of injections and really do see the benefits from that. Local wound care, patients who come in noticing an ulcer or a wound that's just not healing. Usually podiatrists are the first in line to diagnose somebody with diabetes or with vascular issues. For example, I had a patient just Tuesday that had no idea he had diabetes and came in with a wound that wasn't healing, and now he's on a diabetic regimen. He was diagnosed with high blood pressure, so a lot of times we end up being the first person they see that helps get their lifestyle back. And so sports medicine aspects, what I really do, I'm really a fan of is physical therapy. So I always push towards physical therapy and helping athletes get back to with taping and strapping. Now I do nails. A lot of patients do ask, and I do nails, but it's not just a chip and clip kind of a thing. I do see a lot of times where I'll see ingrowns or a lot of diseases that manifest themselves in the nail and we can help diagnose them something that they need to be treated for. So surgically, I do enjoy trauma. We do see a lot of trauma here: bones, tendons, ligaments. Deformity correction. My fellowship, one of the specialties was in deformity, so we see a lot of adults and children with clubfoot. We'd end up fixing that, or flat foot deformities, or cavus foot. Cavus foot is a high type of arch deformity. Reconstruction, total ankle replacements as well too. Not just ankle joints themselves. We will do joint replacements of the big toe. It's very common to get arthritis in there, and patients will elect sometimes to have those joints replaced. Wound care. One of the parts of my fellowship as well too was muscle flaps and microsurgical repairs. So kind of starting to offer people with non-healing wounds, either due to infections or due to diabetes, before the step of a below-the-knee amputation, really trying to save their limbs. Sports medicine, we see a lot here, athletes, a lot of times, chronic ankle instability, lateral ankle, that will end up fixing. External fixators, which I just put one on yesterday, but we do a lot of external fixators as well too. External fixators are great for example, the one I did yesterday with an injury with a patient who was an older patient, had a bad ankle fracture, but her skin really wasn't ready to have surgery right away, so to hold everything in place as her skin basically healed itself, and then go into the internal fixation later. And then microsurgical, I really enjoy nerve repair, and a lot of times the patient who has an injury will end up having some type of their nerve dysfunction as well too, and some doctors will just see bones broken or ligaments broken, they'll just fix those, but there's usually more that comes with an injury as well, and it really doesn't manifest itself until almost after those bones and ligaments are healed, and you have to try to stay up with the patient and do exams. So I wanted to throw a couple cases on here just to kind of show you some of the things I like to hang my hat on. So this was a guy on the left side, and this is graphic, so if you guys don't want to watch or anything, you can close your eyes or anything. I should have said that before I went to this. But it gets kind of graphic, so if you guys are squeamish, just close your eyes. So this is a guy on the left who was diagnosed with necrotizing fasciitis. So I took him to the OR. First step, when you do necrotizing fasciitis, you got to take out all the bad tissue out, and then you leave, limb salvage for later on. So this was him a couple days after the surgery, where he exposed tendons, bones, ligaments, all that stuff you can see. And through wound care, through multiple staging, I was able to put a skin graft on him and get him to heal. And he's back to doing everything he wants to do. So, next case here, this is a muscle flap that we did. This patient actually was an undiagnosed peripheral vascular disease that a doctor did a lateral ankle instability on. She kept on spraining her ankle, and the surgical site just didn't heal. And it just kept opening up. She kept getting infections, and she was afraid to lose her limb. So we did what's called a peroneus brevis muscle flap. Peroneus brevis is on the side of your leg, and what it does, it helps bring your foot up and out, but you have two muscles along there, so you can actually sacrifice one of them, and the brevis itself, which is the smaller of the two, has a great blood supply. So that can be used as a flap to cover wounds. So that's that there. This next one here, this is another muscle flap here. This patient had a chronic anterior tibial wound with chronic osteomyelitis, where we ended up resecting the osteomyelitic bone, so she had a gap. So we threw an external fixator on there to help kind of close the gap, and then used the soleus muscle, which is in the back of the leg. You can actually cut that in half and bring it to the front and help heal those there. This one here, so I got used to seeing a lot of Charcot patients as well too. What Charcot deformity is basically a diabetic who is neuropathic will either A, not feel trauma in their feet, or B, feel the trauma but kind of just ignore it. So the bones themselves start breaking down, and because the neuropathy, they almost become mush. So they get this really bad, almost like a flat foot, but their foot almost looks like a U shape where the middle of their foot is sunk down. So this was fixing the foot, and a lot of times when you have a diabetic, you're really wary of putting hardware on the inside, especially in the Charcot patients, because Charcot deformity will actually keep presenting itself. It will happen, and then a couple months later, the bone will heal and everything will look fine, and then even year, 2 years, 5 years later, the Charcot process will happen once again, even in a well-controlled diabetic. So what we try to do, we try not to put internal hardware because the hardware will actually break down. So we use external fixators to just kind of reposition the bone as best as possible. And then we can take that external fixator off and they don't have any hardware in there. And then we keep following up with them with inserts, diabetic shoes, a crow walker, which is a big boot, just to try to hold that position as long as possible. So, you okay?
Yeah, I'm gonna sneeze.
Okay. I thought you were going to throw up for a second. Here, this was a gentleman who had a wound on the inside of his big toe, had osteomyelitis of that big toe, right in the head there. So, and he did not want his toe in.
You mentioned that a couple times. What is that? Osteomyelitis.
Oh, it's a bone infection. Sorry. Thank you. Okay, that's a bone infection. He had a bone infection of his big toe, and he did not want to lose his toe. Come hell or high water, that toe wasn't coming off. So I resected the bone, and I used this little, it's called a mini rail, just to kind of hold his toe out to place while we let everything heal and calm down. Then we ended up putting a bone graft in there, and he actually has function on the toe. You know, can't really walk too well, but it's just in supportive shoes, and I was happy that he got to keep that big toe.
Would you, if you had your option, you wanted that amputated?
Oh, 100%.
For sure. Okay.
Yeah. I mean, when you look at it there, it just really looks infected. I just wanted to get it out of there, but there was no MRI confirmed, no infection there. It was just a reaction from the infection in the other bone. And so he wanted to keep it. He still has it. So I haven't seen him in a little while, so hopefully he's still alive and okay. But still has the big toe. So this is a lot of athletes who have chronic ankle instability. What that is basically, on the outside of your ankle joint by your fibula, there are a couple of ligaments there. And when you sprain them, they tear, and you hope when they heal that they kind of heal back together and strong. Sometimes they don't. Sometimes they kind of heal out here, and they're very wobbly, and patients will end up getting these recurrent ankle sprains. Especially in high athletes, it's a real nuisance. So what we'll do is we'll actually go in and repair the ligaments. This is the fibula bone here, and this is the ligaments on the outside of the fibula. This is the Arthrex anchor system. I'm not a rep for Arthrex, I'm not promoting, I'm just saying what I use. But it's will just help reapproximate those ligaments themselves to help aid in the athlete's stability and help them return to function. This is a total ankle replacement here. So this is the front of the ankle here with an ankle joint. This is the talus component. So the ankle itself is really made up of 3 bones. The tibia is the bone on the inside of your ankle, fibula is the bone on the outside, and talus is the one between them. And this here is just the replacement here in the joint. You can see this is a side view of the x-ray. Heel, toes, knee is up here. This is the ankle replacement there itself. So, ankle joint replacements are a little tough because the actual implants themselves aren't good for any type of deformity. So if you have a patient who's really, their foot is really out or their foot is really in, there's only a certain number of degrees that the implant can tolerate before the implant will wear it down relatively quickly. So as of right now, if you have a patient who has a significant ankle arthritis, and if there's a deformity, the options are, number one, to basically reconstruct so there's no deformity, wait till that heals, and then do the ankle replacement. Or number 2 would be an ankle fusion. So the implants are getting better. They just came out with the 4th generation of implants, which are a little better at dealing with those deformities, but as of right now, they're really not up to date. Yeah. This is another joint replacement. Sorry, I don't have the picture of him here, but basically this here is a big toe joint replacement. So this is where if a patient has arthritis in the big toe, options would be, number 1, to fuse it, depending on how severe the arthritis is. But if the patient's young, active, really wants to run, continue to do activities, there's joint replacements for that as well too, and they usually respond relatively well. This is nerves themselves here. So if we take the left here, that's the superficial perineal nerve. So it's a nerve that comes from the outside of your leg, goes down to the front of your leg and the front of your ankle, and it provides sensation to the top of your foot. Now, this patient here had ended up having trauma falling, and these symptoms of the shooting sharp pain with some sensation loss didn't really happen until a couple months after the injury. So diagnosed her with that entrapment of that nerve. So we went in, that's the nerve here, and we put this nerve graft over it. So we took out the chunk of the nerve that was damaged, and usually we place this graft on top of it. So the nerve actually will regenerate themselves through this graft. The graft is a conduit to help it regenerate itself. So here, bunions. Bunions is one of the things that podiatrists really love to do, and I do as well too. It's a part of a deformity correction. Now what a bunion is when the big toe, the metatarsal, cranks out in the inside, and the big toe itself cranks out that way. So you get this big bump here. And most of the root causes of it is the joint in the middle of your foot, really that holds up your arch, is called your tarsometatarsal joint. The deformity kind of relies from there. So what I like to do is I like to take out this joint here, bring it over, hold it with plates and screws, and have fusion across that joint. So it keeps the toe nice and straight and helps the deformity from coming back. Okay. This is a patient who ended up having an anterior tibial tendon rupture. The tibialis anterior or anterior tibial tendon right on the front of your leg and helps pull your foot up. Okay, it's actually the main dorsiflexion. Dorsiflexion is when you move your foot up. This guy ended up tearing it due to an injury. So this was a repair. And his tear, so a lot of times with this tendon, when it tears, it will kind of roll up. Similar to what the bicep does. This will kind of roll up, and it's really tough to kind of get a lot of the tendon up from up here, and it rolls down here. So we actually used a tendon graft. It was an allograft there to kind of.
I've never seen one.
Okay.
What was the mechanism of injury?
So he was running, and he actually had he was like a track runner, and a guy tripped behind him and fell while his foot was like this. I don't know if you can see it. It was forced, and he just went down, and it just snapped. So, yeah. So we actually put a little rail on here because when that tendon's healed, you want to hold that foot in a neutral position where it's 90 degrees to the leg. So that was to hold that there and then to repair that. So it just snapped. So, but he returned and doing fine. So this is an ankle fracture here. So this is called a trimalleolar fracture, where basically 3 parts of bones are broken. Bone on the outside is the fibula, bone on the inside is the tibia, and then the third fracture is usually in the back of the tibia, called a posterior malleolus fracture. Now this is one where you can see this was before reduction, and this is one in the emergency department where there's a cast on, but they said that they reduced this. they didn't. So that's, at this point now, this person was a little older, and I went to the emergency department to look at this person, and one of the things that inhibits a surgery for the ankle right away is how the soft tissue looks itself. And this lady ended up having just really swollen, really bad soft tissue. So I put on what's called a trauma frame here, and it's just a delta frame, delta meaning triangle here, to hold her foot, her ankle in the position and to let the soft tissues themselves heal over the next couple of weeks, then to go ahead and do the definitive internal fixation. You take a look, that there is where a fracture blister was. What ends up happening, when you get too swollen, the fluid will kind of go into the skin and it will cause these blisters. And once you see the blisters, it's, you hold off and let that kind of calm down. And then that was her fixation later on. So this was a guy, so your Lisfranc joint is the arch joint in your foot. And this was a patient who ended up having a trailer fall on the middle of his foot there. So he ended up having this dislocation of the joint. So instead of your arch being like this, his arch was kind of like that. Because again, the soft tissue ended up putting on this external fixator on the outside to kind of bring the arch back up and hold it into place, let the soft tissue come down before the internal fixation. I unfortunately don't have pictures of the internal fixation or follow-up after, but this was another guy I had who had a similar injury where he was driving a car, got into a car accident. This was his right foot, where the car crunched into him and his foot just kind of got caught underneath there. So this is where we helped to kind of reconstruct his Lisfranc ligament that way. So we're really not just foot doctors, or we just don't do nails, we do a lot more. And what's great about the training that I received is that, it's allowing me to do a lot more. And what's great about the practice here is that they've allowed me to do all of this stuff. So they've really given me reins to go ahead and do what I've been trained to do and what I love to do. At the end of the day, it's really all about what we can offer the patient, and keeping it here in our home. So if we can do it here without having to have the patient go out, it's great, and it allows me to see a lot of patients and help treat everyone. So appreciate you taking the time to listen. Do you guys have any questions about anything? Nothing? Nothing? What's up?
What do you like to do outside of work?
What do I like to do outside of work? So I have 2 young boys. My oldest one's 2, my other one's 4 months. So they keep me busy. I really enjoy hanging out with them and watching them grow. When I was away in my fellowship for a year, my wife and I were apart. So I kind of missed a lot of time with my oldest one. So I'm kind of trying to catch up with him and then see my youngest one grow up too. I try to go to the gym. I get some in there, but not as much as I'd like. Getting into racquetball a little bit though. So racquetball's cool. By the way, real quick, so we just, Dr. Knappik and I just did a tendon repair the other day. Before you get into activity, just stretch. Okay, stretch before you do anything, stretch during, and stretch after. Okay, it's a lot easier to stretch with a and warm up, exactly. And then if you feel a little twinge, just stop. Okay, just stop. Okay, it's not worth it. It's not worth it. So
over a certain age,
Especially 35.
so just be careful. Okay. And if you guys have any questions for me, if you have something going on, if you have family going on, please don't hesitate to ask. Okay, so you know, an ounce of prevention is worth a pound of cure, and I'd rather see somebody because they just had a question, or you know, than seeing somebody when it's too late. So please don't hesitate to ask. And physical therapy as well too. I'm open. You know, you guys should know that by now. But anytime, anything you need.
for the external fixators, are you just looking at skin, or are you looking at some sort of healing before you go on and do the next surgery?
So it depends. It will depend on the patient. If I know that the patient's relatively healthy, good blood supply, I usually leave it on for anywhere between 2 and 3 weeks and then go in and do the fixation. But if the patient's a severe diabetic, peripheral vascular disease, if I don't put on what's called a ring fixator, so I don't know if you guys know what that looks like, but it's just halos, like little rings on the outside of the foot and ankle. I will either put that on first and keep that on there and just basically allow their body to heal themselves, or convert that triangle frame into an external fixator, depending on the patient's comorbidities. So, what are you laughing at?
I'm nothing.
Okay. So, okay. Anything else? Everything good? Well, thank you very much. I appreciate you taking the time.
Big gastric elongation?
Yeah, gastrocnemius recession.
Yeah. So, what was can you kind of go over the symptoms and then
Yeah, sure.
what you're hopeful
So,
is the outcome for that?
Perfect. Yeah, actually, 2 of those patients recently. So I had one patient was a long distance runner, loved running, but ended up having a lot of pain where his Achilles tendon goes into his heel. And that will be called insertional Achilles tendonitis. And a lot of times that's caused by the Achilles tendon just being tight. So, you know, especially a runner, you know, they're running on the ball of their foot a lot more than on their heel, their Achilles tendon will become tight. So, you know, we'll have them go into physical therapy, strengthening, stretching, and all that stuff, but sometimes it doesn't get it to what he wanted it to. So I end up just, you can either A, take the Achilles tendon and lengthen it, or B, the gastrocnemius muscle, which is the big bulky one on the back of your leg, there's a covering over that called the aponeurosis. And you can actually cut that, and that will actually lengthen the Achilles tendon as well and help increase the dorsiflexion, the movement up of the ankle. A lot easier to recover from than an Achilles tendon lengthening. And I had him back in a regular shoe in like 2 weeks, so as opposed to Achilles tendon lengthening, which takes a little longer. So
When you do the lengthening, what do you do?
so it's an incision on the back of the leg, and so if the back of the leg, if you're looking at it and it's going down into the Achilles like this, I just make a cut right across. Yep. That's it. It's actually relatively easy. Yeah. And it works well, especially in young patients.
How about percentage of strength that you would expect to lose long term?
For the gastrocnemius recession, usually none. The Achilles tendon, usually you get in there, like, I've seen patients like 20%, 20, 25%, they feel it too, you know, especially in runners.
I actually got 2 questions.
Nice.
The first question is, have you ever encountered trauma that you looked at and it was so horrendous you're like, yeah, I'm not touching that needs to go?
100%, yeah.
Can you, like, describe the degree of the case?
Yeah, so first, one of the things I always tell myself is know your limits. You know, and I've had training in a bunch of things, but there's also, I can't do everything, and I'll be the first person to admit that. And at the end of the day, I always think, you know, what's best for the patient. If I'm not comfortable doing it, then I'd rather have somebody who is or better trained at that than I am. We've had patients where the tibia, which is that long bone in the leg, almost looks like it's like a jigsaw puzzle that a kid broke apart and just threw, and there's just pieces all over the place. And you know, with that patient, there's a lot of you know, not just trauma to the bones themselves, but trauma to the soft tissue, and it's very long recovery. And sometimes even just an external fixator or with internal fixation, it's not going to get everything back. So sometimes if I see that, I'll say, hey, I think you're better off. There are people that call pilon fracture, P-I-L-O-N. There are people when they're more severe pilon fractures, they're actually trauma surgeons that are trained, that's kind of what they do. So I would prefer that. If I can do it, I'll do it, but I'll know the second if I can't. That it's better for the patient to send them out. Yeah.
Are there any plans in the works for you to relocate a little closer into?
Yeah, definitely. So, no pressure, right? Yeah. Like I said before, I'm really enjoying it here, and my wife works closer to Youngstown, so it's we kind of try somewhere in between. But we like this area around here. It's really family friendly. It's a great place to raise the kids, and the school system's really good. So that's what Paul and I talked about ad nauseum. So, yeah.
What do you do to relax when you're not at work and you're not entertaining the children? What do you do to relax?
I like to sleep. If I can. Yeah. Actually, me and my wife are watching Brooklyn Nine-Nine. Does anybody watch Brooklyn Nine-Nine? So, it's a 22-minute episode, and I'm lucky if I can make it through about 13 minutes before I pass out. So I'm through season 2, but the way I've been watching, I should be through season 6, but I have to rewatch the episodes all the time. So I try to watch TV, but I can't. So. Awesome. Thank you very much. I appreciate it.